a question that from the beginning of the talk. First, I want to thank everyone for being here and all the researchers for all that you do for all of us here. But my question is about prevention, and you talked about Lipitor and tamoxifen and aromatase inhibitors. I'm wondering how much of the percentages you talk about is also applies to premenopausal women and not just postmenopausal women.
So this is a question about the distribution of the risk reductions that we spoke about. And I want to point out that there are many people, not only on the panel who you've heard from, but in the audience, who can answer this question well. And I wonder if maybe Walter or Pam want to talk about this. Pam? We can bring a microphone up, or Walter will.
While we're bringing the microphone up, I do think it's important to understand that premenopausal women in particular who are at high risk, particularly someone with findings or a diagnosis of something like atypia, benefit in particular. Tamoxifen is a much maligned drug, actually, and Patty Ganz in particular has demonstrated through her quality of life studies that when women don't know whether they're taking tamoxifen or not, they drop out for side effects in the same amount if you're taking the placebo or tamoxifen, with the exception maybe of some hot flashes.
So this is good. So Pam is sitting next to Patty, so we can hear from both of them.
And it's a great drug for premenopausal women. Risks are low.
So we're focusing specifically on premenopausal women at this point.
Can you bring the mic up, please, for Pam?
Sorry?
Here you go. Just hold it closer. There you go.
Okay, can you hear me now?
Yes.
So we're focusing specifically on premenopausal women at this point. I think we've heard a lot about the drug interventions that we can consider, but there is fairly strong evidence that premenopausal women that are physically active actually have a lower risk of breast cancer. We don't fully understand why, and Neil has talked a little bit about some of the mechanisms by which physical activity can impact breast cancer risk, and it may also impact breast cancer outcomes. And some of these mechanisms occur at the level of the person rather than the tumor. So we know that women that are physically active tend to have lower levels of insulin and IGFs, which are growth factors for breast cancer. They can have lower levels of estrogen, more if they're postmenopausal than if they're premenopausal. But really what this is telling us is that although it is never, ever an individual woman's fault that she got breast cancer, I absolutely agree with Dr. Davidson about that. There are things that women can do to lower their risk overall. And in the premenopausal group, physical activity may be the most important lifestyle factor. When you move into postmenopausal women, trying to get your body weight closer to an ideal body weight is also important. So physical activity, and if you're overweight, lowering your body weight. But one thing we've learned is that we don't have to get to perfection. You don't have to get your body mass
index. Thank God
index.
for that, by the way.
Yeah, pardon?
I said thank God for that.
Yeah, you don't have to get your body mass index to 20 to 25 to see a benefit. We see improvements in the physiological factors with modest changes. A weight loss of 10 pounds may actually change the physiology to such an extent that it may impact your breast cancer risk. So there are things that individual women can do. Again, never a guarantee. But there are things that can be done outside of the drug interventions that may lower risk. Patty, do you want to talk a little bit too?
Here you go. And I think the question in part was not only that we can reduce risk, but the evenness of it across the age groups and the distribution. So are there special things for younger people?
So just speaking to tamoxifen, in the breast cancer prevention trial, which included women 35 to no upper age limit, we actually found the same benefit in terms of risk reduction for breast cancer. That is about a 50% risk reduction in high-risk women, in women who were less than 50 as women who were older than that. The important thing is that serious side effects of tamoxifen, such as uterine cancer, blood clots, and so forth, were not found in the women who were less than 50 when they took tamoxifen. And to Denise Grady's comment about who do you go talk to about this, and to George's comment about the fact that we haven't gotten this out to the generalists, most physicians who are not oncology specialists do not feel comfortable talking about tamoxifen, but there is this very strong evidence that younger women who have a high risk, particularly if you've had a biopsy that's shown a precancerous change, that there is up to an 85% reduction in risk. So it's a no-brainer. It's taking a drug for 5 years, and if you take it in your early 40s, you have very few side effects, very few hot flashes, very few other symptoms. You continue to menstruate, and it's a very effective treatment. You don't have to take it your whole life, but I think the trouble we've had is this is a drug that's been associated with treatment of cancer, and really we haven't associated it with prevention. For women who are postmenopausal, raloxifene has been shown to be almost as effective as tamoxifen, and again, that's a drug that's widely used for osteoporosis prevention with relatively few side effects. So there are these options, but you have to, again, find a physician who's going to be comfortable talking to you about this and getting you on the therapy you need.
That's great, thanks. And Hope Rugo wants to weigh in as well. Here you go. So the question is who this would be recommended for?
No, tamoxifen, again, you're talking about in terms of premenopausal women? Anyone. You know, we're really talking about a woman who, in general, to have this kind of risk, has perhaps one first-degree relative, meaning mother, sister, and so forth, perhaps on your father's side of the family as well, who has had a biopsy or two, and in particularly if you have a biopsy that shows a precancerous change like lobular carcinoma in situ or atypical ductal hyperplasia, because then we know that you're already having microscopic changes in the breast that are on this journey towards becoming a cancer. And in that setting, it's a no-brainer. If you could take a drug for 5 years, it's going to reduce your risk by 85% of getting breast cancer. It's something to consider. And the other thing that I always tell women is it's only a pill. If you start the pill and it doesn't agree with you, you can
always
stop.
Right.
Right.
No
Okay.
big deal.